I request Dr. Thomas Cherian to come up to the podium and present on the nuances of managing endophthalmitis.
Thank you, Dr. Meena, and good afternoon. Endophthalmitis vitrectomy is always a distress vitrectomy. We deal with three types of endophthalmitis: postoperative, traumatic, and endogenous endophthalmitis, and here we'll be discussing cases of postoperative endophthalmitis. Pain is one important pathognomonic feature of postoperative endophthalmitis, though it's not mandatory that a patient should have pain. Drop in vision in the postoperative period, that means a patient who had 6.6 on the first postoperative day, dropping to 6.18 or 6.36 in the next subsequent days, always have a strong suspicion of endophthalmitis. We always have had a discussion of endophthalmitis versus TAS. We start with topical and systemic antibiotics, steroids and cycloplegics in a TAS, but don't wait indefinitely with the wishful thinking of a TAS. Always err on the side of an endophthalmitis. Once we make a reasonable diagnosis of endophthalmitis, we inject intravitreal antibiotics and antifungals and maybe steroids. But again, if the patient does not show any sign of improvement in the next couple of hours, always take the patient up for vitrectomy. EVS was done almost 3 decades back, and we have gone much ahead of the EVS situation when vitrectomy was not as safe a procedure as it is today, and we have much better antibiotics for intravitreal use and systemic use today. When the exudates in the vitreous obscure a fundus view, nowadays we take up a patient for vitrectomy and not look for a finger counting or a hand movement or a vision less than 1/60. Also, if there is a worsening or if we don't find an improvement in the fundus view following an intravitreal injection, that case is a case for vitrectomy in endophthalmitis. I'll go through 2 cases. This is my first case of endophthalmitis. This is a fulminant case. Do a 23 gauge vitrectomy here. Clear the vitreous gently so that not to induce much traction, not to induce any break. That is important. The retina is very friable in these cases, unlike the normal pristine retina. These friable retinas are very prone to create breaks, and once you have a break, then the entire prognosis changes. So do a very careful vitrectomy, cut slowly, especially when you go to the periphery, and also when you induce PVD also be very slow. Those bubbles just behind the IOL that are indicative of residual vitreous, even while you are proceeding with your vitrectomy, if you see those water bubbles or air bubbles just behind the intraocular lens, that means you have residual vitreous here. Go ahead and clear that and gently induce a PVD. Again, be careful not to create a break. There are a lot of exudates on the retina. It might tear any time. Do a good dissection, clear up wherever possible. And once you clear, your vitrectomy is done. The next question is whether to inject oil or not. We, of course, inject silicone oil when the retina is found to be unstable, and silicone oil also seems to be protecting the retina and controls endophthalmitis to a large extent. So more often than not, I would inject silicone oil if the retina is unstable in some way. I don't ever look for a break or a detachment, but while you do the vitrectomy, if you find that the retina is fluttering in the periphery, again, for me, that is an indication for injecting silicone oil, but again, not in 100%. And once you complete the vitrectomy, you inject your intravitreal antibiotics. You inspect for any breaks, pull out the ports, pull out the first port here. Here I am injecting the antibiotic through the trocar cannula system. But before injecting the antibiotic, always shut off the infusion board, otherwise what you have injected might immediately egress out. IOL explant is another matter to be decided. If you have a sufficient view of the fundus while you are doing a vitrectomy, you leave the IOL there. If the fundus view is not good, or if you have a very strong suspicion of a fungal endophthalmitis, you can explant the IOL. This is my second case of endophthalmitis, which is a low-grade endophthalmitis. This patient presented with an endophthalmitis in the postoperative period. I am always doing a vitrectomy under the subtenons block. And for that matter, all my vitrectomies are under a subtenons anesthesia. Again, I measure all this. The old habits of doing squint surgery still persist while I measure and go in with the trocar cannula. This is a 23 gauge vitrectomy. Low-grade endophthalmitis where the patient presented with 1/60, injected intravitreal antibiotics, waited for a week, it improved up to 6/60. Again for a week, it didn't improve beyond 6/60, so I decided to go in. So here the vitreous doesn't have that much of exudates, but it's not a clear vitreous. The procedure is essentially the same. You clear the vitreous, taking care not to induce traction and not to induce breaks. And these low-grade endophthalmitis, you don't keep on waiting for weeks or months together. If it doesn't clear within a reasonable time, of course it cleared in the first 1 week but did not clear in the second week, that is the time when you have to take up for a vitrectomy, not beyond that. Here there was some synechiae, posterior synechiae, that also I am trying to release with this. Enter the anterior chamber, inject viscoelastic, and go with an iris repositor and release the synechiae, try to make the pupil round. All these procedures are possible and should be attempted during an endophthalmitis vitrectomy, because left behind this could gradually cause the IOL to slightly subluxate into the AC. So that is relieving the synechiae, again completing the vitrectomy and then pulling out. Here I pulled out the ports and then injected antibiotic. You can either inject through the port or pull out the port, pull out the trocar cannula system and inject the antibiotic and close the case. Wait for a culture report. You have already injected your choice of antibiotics. Look for the antibiotic sensitivity, and based on your culture report and on the progress of the case, decide on further intravitreal injections. Thank you.